It looks like we've got a number of participants who have signed on tonight. I'm sure that we're going to still continue to have more signed on, but I've taken a look at the list of folks who are here already, and I am just thrilled to welcome you and see so many of our students, our alumni, our faculty, and our staff, and friends of the college who are able to join us for this important conversation tonight. I've long admired tonight's featured guest and count myself lucky that in my time at Columbia University, I had such significant overlap with Sandro Galea. One of the biggest influences that Sandro had on me is underscoring the importance of guiding academic public health to engage in and steward conversations about our shared future. And there's never been a time in my lifetime in which that charge has been more important. And I've watched Sandro step up with incredible admiration over the years. And that's only deepened with the thoughtful, inspiring work that he's done in his new book, The Contagion Next Time. Dr. Sandro Galea, Dean of the Boston University School of Public Health, has focused his scholarship on the social causes of health, mental health, and the consequences of trauma. He is one of the most widely cited scholars in the social sciences, and he's one of the most generous to boot. He's an elected member of the National Academy of Medicine and a recipient of several Lifetime Achievement Awards. Now, I could go on, but Ibram X. Kendi, the author of How to Be an Anti-Racist, could not have summed it up more brilliantly. This book can save us if we are serious about saving ourselves. So with that, please join me in offering a warm welcome to Dr. Sandro Galea, and please take a look at the housekeeping slides that Caitlin put for us in the chat. The Q&A will be open, and Sandro will talk, and then we'll have a conversation and then open it up to all of our participants here.
Well, good afternoon, good evening, everybody, and thank you, Dean Fairchild, for that super kind introduction, and thank you all for joining. Thank you all for being a part of this. I'm always aware that in this pandemic moment, there are ever more pulls in everybody's time, and I'm always grateful to people for participating in these conversations. I'm only sorry that I could not be there with you in person, and I look forward to another opportunity to be out there with you in person. So as Dr. Fairchild mentioned, I have a book that just came out called The Contagion Next Time, which I'll talk a little bit about at the end. And what I wanted to do was really talk a little bit about priorities for health in a post-COVID-19 world through the lens of what I wrote about in the book. And I wanted to trace through the pandemic the way I see it and the way I sort of try to grapple with it in the book, really as part of an effort to get us starting to think about what have we learned from this pandemic moment and how do we make sure that we redeem this moment as much as possible, this tragic moment, by learning from it. So with that introduction, let me share my screen. Please stop me if you can't see my slides. So I want to talk about the priorities for health in post-COVID-19 moment, and I will start by perhaps from a not particularly expected place, because I do realize that in a talk like this, you're expecting me to talk about all the things that have gone wrong in time of COVID, and a lot of things have gone wrong in a time of COVID. But I want to start with pointing out some things that have gone right in a time of COVID, and I want to do that with intentionality, because I do think that it's important to focus on what has gone right so we can understand why some things went right and why some things went wrong. So here's one of the paradigmatic things that went right from my perspective. This looks at admissions to hospitals from New York, from the NYU hospital system and a cohort of patients there. And the gray bars are admissions. And more importantly, I want to focus on the blue lines, which are adjusted and unadjusted mortality. They both behave the same way. The only point I want to make is that in March of 2020, when COVID was a new disease, which none of us really understood, admissions to hospital were being met with a 25% mortality. By June, so 3 months later, mortality had dropped 5%. So we dropped mortality about fivefold in the span of about 3 months from a disease that nobody had ever heard of before. That is actually quite extraordinary. That is really the result of improvement in clinical care, growing use of pharmacological treatments like remdesivir, and better non-pharmacological treatments like proning, essentially treating patients with their back up. And these approaches saved enormous numbers of lives. And in fact, while the data is still beginning to emerge on this, the data on clinical care in hospital in time of COVID really is quite good with heterogeneity for particular groups in particular areas, as I'll talk about in a second. And really, I think our health system, our healthcare system, did a tremendous job dealing with a disease that previously none of us ever heard of and was totally unknown in a very short period of time. Of course, the thing that went most remarkably right is the vaccines, that within 8 months of COVID ever having been diagnosed in this country, or at least recognized widely in this country, we ended up with not just one, but 2 vaccines, both more than 90% effective and both extraordinarily safe. It's hard to remember now, but you may remember in summer of 2020, we were having discussions, what will we do if we have one vaccine that's 50% effective, 60%, 70%? But we ended up not just with 1, but 2 vaccines that were more than 90% effective. Now, vaccines normally take 10 years to develop. The previous fastest vaccine we had developed was the mumps vaccine, which took us 3 years. They cost a lot of money. And of course, what went right about vaccines teaches us is that it wasn't just 8 months that it took to get to the COVID vaccine, right? It actually took decades. It was decades of investment in the mRNA technology platform that became this groundbreaking, rapid delivery of vaccine. This is from a paper 10 years ago. And I like this line in it because it's hard to find an academic paper which has a line that proves so prescient, which says mRNA presents a promising vector that may well become the basis of a game-changing vaccine technology platform, which is, of course, exactly what it did. So our healthcare system, the delivery of clinical care to people who are in hospital, our development of vaccines, both areas that we had invested in for decades before, both rose to the occasion and both did very well for us in a time of COVID. Now, of course, so much went wrong, and so much went wrong in this really deeply tragic moment. And we should not forget that we are living through a moment where people in this country and globally really have been living through a tragedy. This is the global map of density of COVID, and this is the global curves of COVID, which I just updated, I think, a couple of weeks ago, most recently, showing the sort of the waves, the multiple waves of COVID. And then the tragedy is compounded, for example, by our challenges in vaccination. This is global vaccination showing the tremendous heterogeneity in vaccination rates, with many countries in Africa, particularly sub-Saharan Africa, having 2 to 5% of our population vaccinated, while other countries have 60, 70, 80% of the population vaccinated. Focusing on the US, because I want to focus mostly on the US in this talk, although I think the lessons from here are eminently generalizable to other countries. This is a picture of the US at one point in 2020. This is from the New York Times. But the reason I'm showing this map is just to remind us that in 2020, there were moments when it felt like the whole country was on fire. They were using here red to color in where there were more cases of COVID. And if you're an alien landing in this country, not knowing what this map represented, you knew it didn't represent anything good. You knew that this was something that was really affecting us. These are the waves of COVID. The Delta wave is the most recent wave. And of course, it was going down. Now this seems to be plateauing, unclear what's going to happen next, or whether we're going to have surges among the unvaccinated. And while COVID has been going on, we have been having this enormous excess mortality from all causes, not just from COVID. This looks at mortality from all causes. The red line is mortality from all causes in 2020. And the gray lines at the bottom are previous 5 years, and the black line is the average of the previous 5 years. And what you see is the excess mortality from all causes is substantially high throughout all of 2020, not just from COVID. But COVID itself, a disease which, just to remind us, as of December 30th, 2019, we had never heard of. The first official cases were December 31st, 2019, although likely there were cases earlier. In 2020, went on to become the 3rd leading cause of death in the US after heart disease and cancer. Now, this is actually quite remarkable. If I were to tell you today that, let's say in 2024, a disease that you haven't heard of, a disease whose name you don't know, it's a word that you've never heard, you haven't heard of right now, but it's going to be this new word, it's going to be a new disease, and it's going to become the 3rd leading cause of death in 2024. I would argue that that actually gives one pause, puts a shiver down one spine, and makes us think, wow, how do we actually avoid that? How do we mitigate the disease? What should we do to make sure that the disease does not happen? Because COVID became the 3rd leading cause of death in 2020 coming from nowhere. It has resulted in substantial downturn in life expectancy. This looks at life expectancy. Here it's divided by gender. And the downturn in life expectancy that we've had from COVID has been the biggest downturn in life expectancy that we've had as a country since World War II. And World War II, we had the big downturn in life expectancy that was driven principally by young men in particular being sent off to war and dying. So as a result, it affected life expectancy. But we haven't had this bigger life expectancy since that time. And when we talk in public health, when we talk about population health science, about the consequences of something like this, when we talk about 700,000 deaths from COVID in the US, we know it's a big number. We know that this is a third leading cause of death. But I do want to always remember that this is 700,000 people, 700,000 mothers, fathers, grandfathers, daughters, sons, aunts, cousins, lovers. It really is 700,000 people who died from a disease that previously was unheard of. And I think nothing we do can erase how much of a tragic year 2020 was, and also 2021, and we'll see what effect it has on 2022. Now, importantly, as we've been living COVID, as we've been living this tragedy, it is critical that this tragedy has not been lived evenly. In fact, there's been substantial heterogeneity across multiple groups, particularly racial, ethnic groups, and socioeconomic groups in how COVID has been lived. Here is one data, this is a data slide from our group, looking at Black versus white mortality in COVID. The blue is unadjusted, the red or the burgundy is adjusted. I just want you to see that the adjusted rate ratio difference about 2.2, that Black Americans had about 2 full times greater risk of dying from COVID than did white Americans. There was also higher rate of dying from COVID for Indigenous Americans and for Latinx Americans, for people with lower wages. All of these are the multiple comparisons that show that groups that have historically borne the greater burden of preventable illness, greater excess burden of morbidity and mortality, were the groups that went on to have most of the burden of COVID. And I'm going to come back to that, but I'm going to focus on the Black-white difference just by way of illustration, even though one could also extend that to differences in other groups. When you look at the drop in life expectancy, this looks at by large gender ethno-racial groupings. And what you see is that the drop in life expectancy for non-Hispanic white women, which is on the right, is about 0.7. Now, 0.7, to put it in context, is higher than any drop in life expectancy we had as a country since World War II. While we had a drop in life expectancy overall in 2016, 17, 18, those drops were 0.2, 0.3. So 0.7 is twice what those are. But if you look to the left of the curve, you see among Black men, the drop in life expectancy is 3 years. 3 years is a huge drop in life expectancy. And Black men as a group in large gender ethno-racial groupings have already substantially lower mortality compared to all these other groups by more than 10 years. It's already a pre-existing difference between Black men and white women, for example. So really, COVID has been experienced as a tragedy, and it's been experienced as a tragedy across groups, unevenly across groups. Now, here I'm talking about racial groups, but I also want to point out the impact of COVID and the impact of the consequences of COVID on other groups, particularly people who are low-wage earners who are already socioeconomically marginalized. This looks at the drop in employment that happened in the first quarter of 2020, where employment in this country went down to lowest levels it has had since 1975. And importantly and critically, that while there was a drop in employment for everybody, among high-wage employment recovered by June of 2020. And in fact, as of this summer, high-wage employment was almost 10% higher than it was pre-COVID. By contrast, low-wage employment has not recovered, still about 20% lower than it was before COVID. Another way of looking at it is this way. This looks at income quarters. And what you see in the top row, you have highest income quarter, second income quarter, third income quarter, lowest income quarter. And what you see is that essentially all job loss, which is to the left of the line, has happened in the lower half of income. In the top half of income, there's essentially been effectively a net income gain. So this loss in employment, which of course compounds the illness from COVID, which is accumulating to people who are in general were demarginalized, people of color, people in low-wage jobs, people in retail, people in trades. And those are the groups that have borne the full brunt of consequences of COVID, both from the point of view of the disease itself, as well as the consequences of our effort to mitigate the disease. To look at it another way, this looks at the data from the Congressional Research Service, and this looks at unemployment rate. And here you have three different groups, but you can just compare black and white just for the sake of comparison. We're going to follow that comparison through. You have pre-recession, peak, and current. So you see black unemployment was 6 before COVID, went up to 16, now down to 9. White was 3, up to 14, down to 5.3. Looking at another way, looking at by high school education, you see less than high school graduates, some college or 4-year degree or more. Comparing the top left and the bottom right, less than high school, it started from 5.7, went up to 21, then went down to 9, while in a 4-year degree or more was 2, went up to 8, and went down to 3.5. So fundamentally, what you see is that while everybody was affected, the extent to which different groups were affected varied dramatically, and the extent to which there was recovery from COVID varies dramatically across groups, drawn broadly around socioeconomic axes, around racial groupings. And what's even more heartbreaking about this is that this, in many respects, did not need to be like this, and other recessions have actually not been like this at all. This looks at prior recessions, 1990, 2001, 2008, and the coronavirus crisis. And from left to right, it follows the months after the recession. And you see two lines. One is the green line and one is the purple line. The green line are people in the highest earning quartile, and the purple line are those in the lowest earning quartile. And what you see is in the 3 prior recessions, although there was some splaying of those two lines, meaning people in the lowest earning quartile had more job loss than those in the highest earning quartile. In the coronavirus crisis is when we had the most separation of those two lines. And that's, of course, because when COVID hit sectors of the economy that were principally that we, to try to mitigate COVID, then ended up constraining, which resulted in consequences accumulating among the lowest earning quarter of the population. And a lot of that had overlap with people of color in this country. We saw in 2020 this enormous surge in civil unrest and civil protest, which is legitimate civil protest around these deep injustices. Now, this was triggered specifically by the killing of unarmed Black men and women, particularly George Floyd, but also many others. But it wasn't just that, right? This was at a time in the middle of COVID when these injustices at the heart of these inequities I'm describing here, inequities in the burden of COVID, inequities in the consequences of COVID, were becoming clear, sharply clear, perhaps for the first time in recent memory, which saw more people participating in civil protest than really the country has ever seen. It's about 10 to 20 million people participated, which was more than even in 1968. And all of this was an expression of these deep-seated racial socioeconomic injustices that fundamentally shape our society, that in non-pandemic times, we have come to accept as just the way we do things. And the pandemic illuminated them. The pandemic brought them to the fore. In many respects, there was nothing new about the pandemic. I mean, I could have told you a lot of things I told you now, you asked me here 2 years ago, 3 years ago, but the pandemic illustrated those. So understanding these forces, understanding what happened in COVID, I think it's worth pausing and say, why did it all go so wrong? So what did we get wrong? Now, there's a lot that we got wrong in time of COVID. And I'm sure in the Q&A, we'll have opportunity to talk about other things, which I'm not going to address here because I really only want to talk for about half an hour. But I want to focus on, to illuminate what went wrong, I want to focus on the black-white difference in mortality from COVID, because I think it's a helpful microcosm representing the broader picture of what went wrong in the time of COVID. So why did it all go so wrong? And I'm talking about all, but here I'm going to focus on the black-white difference in mortality. So the black-white difference in mortality is explained by 2 factors. Number one, it's explained by unnecessary uneven risk of getting COVID. Now, what do I mean by that? Well, how does one get COVID? COVID is a respiratory virus. It's transmitted person to person. Well, the way one does not get COVID is by not being around other people who may transmit the virus to you. Everybody here knows that. I understand that. Well, how did we protect ourselves from COVID? Protect ourselves from COVID right at the beginning of the pandemic through largely stopping being around other people, through working from home. Well, who could work from home? People who could work from home were people who had the socioeconomic means to work from home. So you take a look at this graph. The national emergency was declared in March of 2020. The red line are the bottom earning 20%. The gray line are the top earning 20%. And you see this incredible divergence in who can work from home. People with more means could work from home. People with fewer means could not work from home. And of course, that is the period where one was then accumulating risk of getting COVID. Looking at this another way, this is from data from the Bureau of Labor Statistics. This is by income quartile, and this is the percent of people who are able to work remotely. So what you see here is this pretty straightforward dose-response relationship, right? The higher the income quartile, the more likely you are to be able to work from home. What essentially this creates is entirely different lived experiences in a time of COVID, where if you're in the top 25% of income quartile, sort of feels like everybody around you is working from home. Well, if you're in the bottom 25% income quartile, it's like nobody you know is working from home. And this reflects this economic patterning that exposed people to disproportionate risk of COVID and risk of COVID that we as a society did not know how to mitigate. And of course, this has overlap with racial groupings, and this looks here at likely employment in the essential industries, which is not a direct parallel to the previous slide, but there's a lot of overlap, where you see that Black Americans are more likely to be employed in essential industries than other groups. So reason A was differential risk of being exposed to COVID, which was driven by social and economic patterning, which exposed different groups to differential risk of COVID. Now, once people got COVID, though, there's reason B, which is the unnecessary risk of severe COVID, because having COVID by itself is not enough. Yes, there's differential there, but that does not explain the full difference. The full difference is actually explained by differences in severity of COVID. Well, what explains differences in severity of COVID? Well, we've known right from the beginning, this is a slide from the China CDC from February of 2020 that shows that death rate for COVID varies depending on underlying disease. Cardiovascular disease, diabetes, chronic respiratory disease are risk factors for dying from COVID. In fact, one of the things that's been not well communicated is that if you had no underlying disease, your chance of dying from COVID, even pre-vaccine times, were actually quite low. So it is having underlying morbidity that makes you at risk for severe COVID and death from COVID. Well, who has those patterns of underlying morbidity? Here's one way of looking at it. This is by household income decile. The more you go to the right, the higher the income. And if you look at the yellow bar is having illness that makes you vulnerable to COVID. Higher income decile, the less illness you have that makes you vulnerable to COVID. The green bar, by the way, is long-standing mental health condition. The higher the income decile, the less mental health condition you have, which itself predisposes you to then having mental illness during and after COVID. I'm not going to talk about mental health right now, but I'm happy to take it up in the Q&A. So fundamentally, the more income you have, the more protected you are from COVID because the less underlying disease burden you had. And of course, that is patterned by underlying inequities in assets that result in equitable distribution of underlying disease. In particular, going back to the Black-white American comparison, this looks at two underlying risk factors commonly found, high blood pressure and diabetes. And you see that high blood pressure has higher prevalence among young, middle-aged, older age Black American versus white Americans. And of course, all of this is inseparable from the history of marginalization and disadvantage that particular groups, particularly Black Americans, have been subjected to in this country, going back to the tradition of slavery, the history of slavery and the enslavement of African Americans in this country, and the 400 years of that, which here, this looks at a map of slavery in 1860, which of course, when slavery was abolished, it was followed by Jim Crow laws and followed by multiple other efforts at institutional structural racism, including, for example, the practice of redlining. So redlining was a practice that emerged from a federal government effort to encourage banks to lend money for mortgages. But part of that effort was the Homeowners Loan Corporation that would take maps of cities and color them in green, yellow, red, green being encourage areas for a mortgage, red being not, red hence the term redlining, and of course red areas where Black Americans lived. That resulted in Black Americans being less able to buy homes, less able to accumulate wealth, having fewer assets, having jobs with lower wages, having greater underlying burden of morbidity and greater risk for severe COVID today. So really, I'm obviously connecting dots very quickly, but I'm trying to illustrate that the greater disproportionate burden of poor health is inextricably linked with a history of marginalization, disenfranchisement, and disadvantage that's been borne by particular groups, particularly people of color, particularly Black Americans in this country. So understanding how things went wrong, the question then becomes, why did we get this so wrong? And in the spirit of why do we get it wrong, I'm sort of doing that to try to point out how we can actually do better. How can we do better? So I would argue that the reason we got it wrong is because historically we have underinvested in what makes us healthy, and historically we have underinvested in what could keep us healthy. So let me just talk about each of them for a moment. And I'll start with underinvestment in what makes us healthy. And I'll use a metaphor to tell the story. And I'll use the metaphor as a real story of Blind Willie Johnson. And this is Blind Willie Johnson, who was a blues singer who was born in Texas at the turn of the 20th century. And Blind Willie Johnson, the story goes, was born sighted, but lost his sight in age 7 in a domestic violence incident. He grew up poor, blind, Black in Texas. He learned to play the guitar. He made a living busking, not a very good living, as you can imagine, but that's why we remember him. And Blind Willie Johnson was married and living in a small house. And at one point, the house burned down, but him and his wife didn't have much money. They weren't injured in the house fire, but they were essentially homeless. So then they went back to live in the burnt out shell of the house. In his 40s, now we're dealing with 1940s in Texas, Blind Willie Johnson got malaria. Now, malaria was pretty common in Texas in the 1940s. Some of you may know that the Centers for Disease Control, the CDC, was initially started to help control malaria in the southern states. His wife took him to hospital, and and he was turned away from hospital. And it's not clear if he was turned away because he was poor, because he was blind, or because he was Black. And then he died. Now, the reason I tell the Blind Willie Johnson story is to ask what killed Blind Willie Johnson. And of course, what killed Blind Willie Johnson was malaria, right? Had he received treatment for malaria, he would have lived. But I tell the story to indicate, to show, because I think everybody will agree, it wasn't just malaria that killed Blind Willie Johnson. It was also poverty, it was also racism, it was also domestic violence, it was also poor access to care, it was also homelessness. But the reason for the story is because our understanding of the Blind Willie Johnson story in this country continues to be that the cause of death for Blind Willie Johnson was malaria, just as our focus in COVID times has been just on the virus, when the other conditions that shaped his life were as important and more important for what ultimately resulted in his death and the age of his death than was the pathogen itself. Now, I could tell the Blind Willie Johnson story in a sort of infographic way. This is data from the Institute for Clinical Systems Improvement, showing that medicine and healthcare, which is the bottom gray part of the legs of the figure, are about 10-20% of our of what causes health, but health behaviors: tobacco, diet, exercise, alcohol use, our communities where we live, our urban environments, family social supports, our incomes, those collectively matter much more than does medicine and healthcare. But despite that, despite knowing that, we actually, this figure here on the left in black and white is the same as the colorful figure I showed you before, same proportions. On the right, you have a figure which shows the spending. Our spending, 90% of our spending is essentially on medicine and healthcare. So to go back to Blind Willie Johnson, even if we understand that story and the figure on the left suggests we understand it, we spend all our money essentially on malaria. Now, we spend a lot of money on healthcare. We spend a lot of money on healthcare. This is our spending on healthcare. The blue line, top blue line, looks at spending on healthcare compared to all the other high-income countries, which are all the other colorful lines. We spend about 40% more than the next closest country on healthcare. And while we're doing that, we're spending less on everything else. This is projections, leaving aside Social Security. The blue line is healthcare program spending, and the gray line is other spending. You see healthcare program spending increasing, other spending going down, which is in gray. And we have long paid the price for this. We have long paid the price for this because before COVID, we were already a country that was living sicker, shorter lives than other high-income countries. We were living 5 years less than other high-income countries. Our life expectancy was about 5 years less. We had already seen a downturn in life expectancy in 16, 17, 18, although nowhere near in magnitude to what we had in the context of COVID. And because of the forces that we're neglecting, because of how we're spending money, because also that spending was uneven, we already had deep-seated racial health inequities. This looks at now mortality, Black versus white mortality at young age, middle age, older age, again, showing this deep-seated inequities as part of a general pattern of poor overall health. Perhaps this one slide captures sort of the state the country is in best of all, because we have health expenditure on the x-axis and life expectancy on the y-axis. And you see all these countries, you spend more and you get more, but not us. You spend more and you get less. We sort of fall off the curve. We're like off the curve in terms of our spending and what one gets out of it. Health is the only sector where we spend more than other countries and get less, and where we accept that. I would argue we should not accept that. And this is, remember, this is pre-COVID now. I'm explaining why, what we underinvest in pre-COVID. And I would argue that if our smartphones, for example, if I were to tell you that our smartphones cost more than they did in Canada, but they held less data, they were slower, and they had less screen resolution, we wouldn't be buying our smartphones. But we somehow accept it for health. And fundamentally, it is because we're spending in the wrong areas. We spend all our money on malaria and ignore everything else. And similarly, I'm hoping that now people are connecting to where I started with COVID, where our areas where we did very well in COVID were really in the treatment of malaria. Remember, in the vaccines and the clinical treatment. And we did poorly in everything else. And everything else is what we have neglected before COVID and what we neglected during COVID. The second reason why we did so poorly in COVID is we've underinvested in what may have helped, which is fundamentally public health, the force of public health, that COVID found us unprepared to mount rapid testing, screening, testing, detection. And we have had a drop in state and local police forces. I apologize, state and local public health forces in throughout the country. Our most states spend less than $100 per person in public health. And even though there has been things like the prevention fund, which suggests there'll be more public health spending, often the actual amount of spending is much less than that. The reason I jumped ahead to police because I was looking at my slide ahead to show that actually most local governments spend more on police than they do on public health. The red is higher spending on police and the blue is higher spending on public health, which of course ties back in a lot of the problems that I talked about earlier that were driving the social civil unrest that we saw in the country. So with that picture, the fundamental point I'm making here is that it is an underlying picture of us being ill-prepared because we do not invest in the areas that could generate health. And we have allowed ourselves as a country to be in poorer health than we need to be and with more health inequities than we should have, which then we're all exposed by COVID. In many respects, COVID was nothing new. COVID really illuminated what we knew and what we should have done long before COVID hit. And hopefully COVID put these front and center in our mind in a way that we'll now not forget them. So seizing the COVID-19 moment of opportunity, this is to go back to my point, we've known a lot of the things that need to be done. COVID just made them clear for everybody. This is a piece which I actually wrote for US News. And if you look at the date, it's March 1st, 2019, long before I had ever dreamed or had a nightmare of COVID, essentially articulating this argument that I'm making here, what I'm calling the blind Willie Johnson argument, that we are going to be unhealthy as long as we only tend to malaria and not to everything else. And of course, COVID could not have made that any clearer. We were successful in our treatment of malaria. We were successful in our rapid development of vaccines. We were successful in our treating of people once they were in hospital. We were abysmal failure at having people who were sicker than they had to be, having people more exposed to COVID than they needed to be, all of which contributed to the tragedy that is COVID. Now, the good news is that everybody in this room, you all in this room are in the area of medical science, broadly speaking, at least as used in the poster's language, and confidence in you and your work and us and our work is high and increasing, which I think puts us in a really good place to be able to make these arguments and hopefully make them as clearly as possible in a way that they are indelible. I have in the past made the point in my writing that we should be working on two axes. One is in creating knowledge that can inform action, and one is in arguing for the values that allow action. So with these two axes, and we fundamentally want to be in the right square where we know what to do and we are collectively convinced as a society it is the right thing to do. And we have seen a lot of stumbling around that in time of COVID. For example, while the vaccines give us knowledge that can inform action, we also had a lot of mixing around whether or not people are willing to accept the vaccines, showing how unless we work on both axes, our work we will fall short on creating as populations as healthy as we want them to be. So I'm going to end here, and I will end with Dean Fairchild asked me to end on something else, which I've written a little bit about, which is about doing ever better science in a time of COVID. I think we, in the same spirit as I feel confident saying that there were some things we did very well in terms of COVID, there are other things we did poorly. And I think public health science and public health practice, there's a lot of areas in which we could have actually done better. I'm happy to talk about more Q&A. I've written a couple of pieces on this now. But fundamentally, I think we have not risen to the challenge of actually meeting populations where they were at in terms of giving them the approaches that populations recognize that they need in order to preserve their health in a time like this. Dean Fairchild was kind enough to mention my book, The Contagion Next Time, just came out last week, which is really about exactly what I talked about here. So when I set out to write this book, the book just came out last week, which means it was written a year before, which was sort of in the fall of 2020. And I thought at that time that at this moment in time, we are going to be having more and more books written about vaccines, about surveillance, about stockpiling, about the need to make sure we have the therapeutics to prevent the next pandemic. And I wanted to make sure that at least there was one book out there that made it clear that all of that is good. All of that is good. All of that's important. Remember, vaccines were a triumph. Clinical care was a triumph, but it is a necessary but vastly insufficient unless we also tend to the underlying social and economic inequities, the underlying social and economic structures that generate the world we live in, that fundamentally generates our health in regular times, and particularly in time of pandemic. I will stop there because I very much look forward to the conversation. Thank you again for having me. It's a privilege to be with you.
Thank you, Sandro, and thank you everybody who has been part of the conversation. A reminder, we have one question in the Q&A. I will come to that in just a little bit, but remind other people that you can put your questions in the Q&A, and we'll get to as many of them as we can. But I'm going to take advantage of my moderator's privilege and have a little bit of a conversation with Sandro. So Sandro, one of the things I know you have written about before is trends in NIH funding, and it comes back to this question of the two axes that we have to think along, not just science and values, but medical care, access to affordable medical care, and structural change. As a field, and I'm not talking about your college or my college, but as a field as a whole, have we given enough attention to the question about structure? Have we fallen into the kind of deadly trap of following NIH funding, which has tended to favor genomic over prevention, clinical care over prevention? And are we essentially asking the wrong question as a field? Not how do we prevent people from needing medical care, but how do we fix this problem, and maybe as a way to avoid changing some of the underlying social relations, social conditions?
Yeah, so let me perhaps address that from a more fundamental level, perhaps a more radical level. And let me just give us a causal chain. And let's say that, can we all agree that poverty leads to poor housing, which leads to pathogenesis, leads to health? I suspect we can all agree to that. I suspect one could agree to that in very different color political stripes. So if you agree to that, then you say, well, these are all equal and important parts in the causal chain. Now, let's take NIH. Well, there is a National Institute of Heart, Lung, and Blood. There is no National Institute of Housing and Health or National Institute of Poverty and Health in NIH. Now, I think we're so used to think of NIH in a particular way that somebody's going to say, well, that's absurd. Why should there be a National Institute of Poverty and Health? To which my answer is, well, why shouldn't there be? I mean, it's simply another point in the causal chain. We're just accustomed to thinking about the pathogenesis part. I go back to Blind Willie Johnson. We essentially have many National Institutes of Malaria and Health, metaphorically, but we have no National Institute of Domestic Violence and Health, of Poverty and Health, of Structural Racism and Health, all of which equally well, if not more, contribute to his health. So our entire system, our entire lens of looking at research funding comes through this very mechanistic pathogenesis approach, which right away overprivileges the mechanical and the biological over the social, which is equally as important. Now, in the past several years, particularly in the past decade, NIH has had this enormously deep dive into the genetic and molecular, a lot of it under the umbrella of precision stuff, precision medicine, precision public health, etc. And that has come even more at the expense of the population. And I don't think you can have it both ways. I think if one agrees with my argument that the social and economic matter as causes of health, I don't know how we can go about, from our largest funders, ignoring funding questions about social and economic causes of health. But somehow we do that. Like actually somehow, I can talk to leadership in any number of biomedical research institutions, and they all agree that yes, there are social and economic causes, but we're not structured to deal with them. We don't know how to deal with them. And I just think that's a shortcoming. That's a lack of imagination on our part. And that is that underlies so much else that we fall short of.
Well, and one of the things I've always appreciated, Sandro, is that you understand that we have to think about these issues in light of a broader historical context, choices that our field has made, choices that medicine's made, choices that public health has made. Can you talk a little bit about your choice for the book title? It's playing on this same theme. You've made the point that this isn't a book about preparedness. In some ways, as I read it, is a book about history and playing on Baldwin's The Fire Next Time, the Contagion Next Time. And of course, Baldwin is somebody who has so eloquently made the case for embracing a robust, complex, painful view of history as being vital to the project, the political project, to the civic project that we have to do as Americans.
Yeah, you captured it beautifully. It's the book, as I say in the epilogue, I save it for the epilogue as a way of rewarding the reader who makes it through the book. But as a bit of I guess, spoiler alert, the book is an homage to The Fire Next Time. And it's exactly for reasons that Dean Fairchild has mentioned. It is the book is not only about structural racism, but structural racism, one of the forces I dwell on in the book, just as I dwelt on it a little bit here. But the aim of the book is to make us really face what to my mind is self-evident, that we cannot mitigate the consequence of a pandemic without tending to our underlying social and economic structures, without tending to availability of housing, within which people can actually distance themselves from others if they need to, without tending to making sure everybody has a livable wage so that people do not feel like they have to go to work where they are exposed to COVID if they're at risk for COVID, without tending to forces that ultimately shape everything around us. So the book does call for a harsh light cast on many aspects of how we live. And I'm using the pandemic, admittedly, and I'm upfront about this in the book, as a bit of an excuse to talk about these forces. I could have talked about these forces years ago, but I'm trying to say, if we do not pay attention to this now during the pandemic, then when will we?
Thank you, Sandro. So one of the themes that's coming up in the questions is taking us back to the Kendi quote, that if we want to save ourselves, we need to read this book. So what are some of and certainly one of the themes in the questions is the role of evidence, the role of misinformation. So can you talk specifically about the role of evidence, the role of misinformation, but also about our obligations as a field to be advocates in terms of being evidence stewards, policy stewards? It's been a debate in public health for a lot of its history. Should we simply let the science speak for itself? And it's been protective at some moments in time, and in moments of under political scrutiny, being able to retreat into the science has saved public health in some particularly contested instances. And certainly in epi, there's been a long debate about, should we be advocates or should we be scientists? So can you talk about those two dimensions of communication? So how do we need to be thinking about misinformation at this moment in time, and how do we need to be thinking about advocacy, which both involve being more thoughtful, I think, in how we as a field communicate with the public and engage in the public conversation?
Yeah, so we could spend hours talking about both of those, but let me try to tackle. Let me start with misinformation. We one of the challenges, which I didn't address at all in my talk, but I could talk about, that we had in time of COVID, is that this was the first real crisis that we lived through the lens of social media as a substitute for a public square. Now, social media is a very poor substitute for a public square, because social media is an algorithmically driven medium that elevates emotion and disagreement and confrontation. That's fundamentally how it's designed. So because we are new to social media, we have lived this moment through this emotional confrontation platform, which has resulted in this enormous polarization. If one thinks back to 9/11, 20 years ago, 9/11 was the first crisis, large crisis, lived through the lens of 24/7 news network. And after that, once things calmed down, we actually were able to look back on it and see what we learned and about how that went along. But if you think about it, the Patriot Act, which was passed with every senator but one agreeing it was a good idea right after 9/11, in no small part influenced by the hegemony of thought coming from 24/7 News Network, now is broadly seen as a real failure, as a real abrogation of civil liberties, and as a mistake. So we made mistakes then because of the dominant medium of choice. We're making mistakes now. So where does misinformation come from? Misinformation comes from these enclaves, these pockets of information that then are wrong and that become the only information that groups get. Hence, we call it misinformation. The world has always had charlatans and quacks who go around and say various crazy things. And it was never as much of an issue because we never had ways to isolate ourselves and say, I'm only going to hear one thing and one thing alone. And I have a lot of information coming at me, but it's all being amplified through this medium, and I'm hearing one thing alone. So I don't think that the issue is misinformation per se. We've always had misinformation. If you go back historically, I mean, you're the historian, and there's been misinformation about all sorts of things over time. There was misinformation in the plague, all sorts of things. But the unusual thing we find ourselves in now is that you have large segments of the population, because of the way we've structured our communication, who can hear only that misinformation, and there's no way to penetrate the bubble. And I actually think we need to grapple with how to change that, because we will not move forward on this unless we change it. Now comes the role of science, and that was the role science play in information spreading and in advocacy. I think science has a key role to play in spreading its results of its findings, making those accessible. And I think science should also play a role in arguing for the right values that inform where we go forward. Now, having said that, I also think that science has been poor at the latter in this moment in time, because science is tremendously unaccustomed to working as quickly as it has. And science has, to my mind, been caught up in the trap of the social media echo chamber. And when one looks back critically and harshly at what a lot of science has done, there's been tremendous amount of communication that has been non-helpful and non-productive. So I do think that there's a lot of reckoning to be done in science about our role in spreading information and how much of that has really contributed to a better world and how much of it has not. Obviously, I'm not answering the question. I'm actually opening up a whole other box of questions.
No, and thank you. Thank you, Sandro. And we have so many good questions here, and a number of them are from our students and faculty. We won't get to all of them, but students and faculty, I think Caitlin and Misty are tracking. If you your question doesn't get answered, I will give you a copy of Sandro's book. So we have some here. So that's my promise to you, because this is one of our goals is always not just to have somebody come in and talk and then leave, but have this be a spur for continued conversations within our community. But one of the things that that picks up on this theme, and then I'm going to change tracks just a little bit, comes from one of my staff members who asks, how can public health galvanize communities and individuals to notice and care about justice enough to act? And I might then pull that in with Deborah Mosier's question from the CDC and say, not just act, but act now. Why wait till the pandemic next time, the contagion next time?
Yeah, I saw that's a great question. Well, I've been criticized for writing this book too soon. So it's good to actually get some nudging from the other way. Well, maybe it's even too late. The only way I know for public health to do this is by doing this, actually, and this is why I'm grateful to you for the invitation. I'm grateful to everybody for being part of this conversation. We simply need to surface these issues. The forces of focusing on malaria and treating malaria are many. They're legion. The forces that are trying to push forward these ideas they articulated in this talk, these ideas that I know everybody here on this call thinks about every day, are quite outmatched. To go to the musical Hamilton, outmatched, outnumbered, and outmanned, and that's really how I feel often in public health. Like, we are not telling our story anywhere near as effectively as we could. So I often tell our students that when I write a book like this, it's really what I'm trying to do is encourage our students to write better books, because I'm sure they can, because they're much more dexterous with telling stories than I am. I'm just an epidemiologist. I grew up in a sort of fairly linear way of thinking when we were going through. And when I talk to our students are getting, I hope, are getting inculcated into a way of thinking where public health needs to make its arguments more clearly and more strongly. And so I have no doubt that to all the students listening, that you're going to do a better job, and that what the stories you're going to push forward are better than the stories that Dean Fairchild and I can push forward.
And Misty will probably kill me for saying this now, but one of the things we've been talking about, so I'm going to encourage you to do it now, is giving an award for students, faculty, or staff who write the best op-ed of the year, or some publications.
Cool.
I'll make this will be the formal launch of that, details to follow, but it picks up on this theme of pushing the public conversation. So those of you who do it will put together a committee, and we'll evaluate those and make this part of our tradition here at the College of Public Health. One of the things I want to do is, since there are a lot of questions along the same themes, but one of our new faculty members gives us an opportunity to think about the focus a bit differently, perhaps. She asked if you could share your overarching observations on racial and social economic disparities in mental health during the COVID-19 pandemic.
Yeah.
Many scholars warned about this being a psychiatric pandemic. Certainly, we've heard that on campus, that masking, that testing, that we're driving students to mental health crises through our protective measures. And I think Parvati's question is a more robust question than that. But how are you thinking about mental health in the context of the pandemic?
Yeah, so the evidence is accumulating about mental health. Number one is there was a tremendous increase in mood anxiety symptoms and disorders during the pandemic, which actually stayed persistently high during the pandemic. So we know that there was about a threefold jump in reported mood anxiety symptoms, which stayed high for the whole year, sort of 2020, from second quarter 2020 all the way second quarter 2021. We also know that those symptoms and diagnoses were unevenly distributed, that people who were experiencing more socioeconomic stressors were the ones who had substantially more mental illness. So it is groups who are already vulnerable and groups who were exposed to stressors like fear of losing a home, problems with childcare, problems with elder care, fear about losing a job. Those were the groups, and the burden, the excess burden in that group is about fourfold higher than groups who did not face such stressors. So it's a really dramatic difference. So poor mental health became yet another burden that accumulated to groups which were socioeconomically already marginalized and disadvantaged more by the pandemic. Thank
you, Sandro. One of our questions from one of our students, he notes that mortality is stratified not only by race, but also by gender. And he argues that this intersection between race and gender, and Lem, you'll forgive me if I'm summarizing your question clumsily, is overlooked. And why is it overlooked, particularly with feminism and racism movements? Black women, he argues, are getting a lot of attention and support, but why is this not the case for Black men? Would you?
Yeah, I'm looking at the question now. Yeah. Yeah. This is yeah. Thank you for the question. Yeah, I don't know. I don't know why it is. I can speculate why it is, but and broadly, I think it goes back to the bucket of issues about what stories we tell as a society and what stories we surface. And I can't help but feel like the lens through which we have seen the world of health, which is a very reductionist biomedical pathogenesis privileging lens, has distorted all sorts of things, including this one, including which is the deep disadvantage that Black men in particular face on multiple axes of health and well-being. I just think we haven't had the space for those stories in our society because all the oxygen is taken up by the treatment for malaria, to keep coming back to my metaphor, just because I think it's handy. So I do think that these are the narratives that we need to make sure we push forward, such that the narratives are stratified in the public imagination by their importance to the health and well-being of the public. And right now, there is a mismatch. There's a real mismatch between what matters to the health of populations and what the media narrative is on. One of the interesting experiences when you publish a book is I've done a number of sort of book launch events and then you get odd questions from the audience. And I can't tell you how often it happens. I present the topic of the book and I think, well, I've been convincing, there you go. And then somebody raises their hand and the first question I get asked is, well, what do you think of this pill? To which sort of my reaction is, well, I've actually been talking about everything except for the pills you should take. But that's what's on people's minds. And so I just think our narrative is so overwhelmingly in one area that we don't have space for narratives that illuminate these other critical issues.
Thank you. So I'm gonna go to the last question, and this may have to be the last one for the night, but to me it also relates to a question that somebody else asked about surveillance and surveillance systems, and yours is a book about the U.S., but of course, not only do we not have appropriate global surveillance systems, we don't have appropriate surveillance systems in the United States. We don't have vaccination registries connected to COVID registries and connected to diabetes and chronic disease registries in easily interoperable ways. And this, I think, goes back to some of the discussion you shared before about our rather siloed approach within the NIH and the way we think about these problems. So can you imagine from an academic public health approach, can you imagine a research approach that helps us demonstrate this point in an effective way? And I'll tie in with our question from our colleague at the CDC. So in a way that allows us to act on it as both academics, but also as a broader community of citizens.
Yeah, I think one can imagine that. One can imagine an investment in the kind of big population health science that currently is largely reserved for big genomic science, where it's well understood within the genetic molecular world that you need large numbers of people in order to power the differences in finding genetic factors associated with disease. One could get away with fewer people than that, but one could use these large cohorts that adequately characterize the social and economic context and show how it shapes people's health over the life course. I barely even touched on life course here in my talk, but of course, the full expression of health over the life course is a part also of the same narrative, that health is generated not cross-sectionally, but longitudinally over time. So yes, absolutely. And I tend to think that the more such studies, the more weight there will be to shifting the conversation in a particular way. And ultimately, I come back to this, which is taking the data to convey the narrative that creates the conversation, because the conversation is what then is the substrate from where those who are elected to decision-making authority positions emerge, from people who run private sector companies emerge, and then decisions made will reflect the concerns of the health of populations. And right now, that doesn't happen.
Well, Sandro, that brings us to the end of our time with you today. You brought us full circle in some ways by coming back to Life Course. We're not looking at a particular moment in the lives of individuals. We have to think about them over time, just as we have to think about these challenges, not in the moment, but in terms of our broader, the history and policy and ethics of public health and healthcare. So thank you, everybody, for your attendance. Thank you, Sandro, for challenging us as always.
Thank you for having me. Take good care, everybody.